Welcome to our next in a series of talks on Asian health issues. My name is Bryant Lin. I'm the co-director of the Center for Asian Health Research and Education. I'm proud to bring you this series of talks, which are co-sponsored and co-hosted by our very own Stanford Health Library. Great thanks to the Vincent V.C. Wu Foundation for underwriting these talks as well. I'm really pleased to welcome Dr. Dimitrios Colevas. He will be speaking on nasopharyngeal carcinoma, what it's about, who gets it, and what we're doing about it. He will discuss this entity in the context of epidemiology, virology, standard treatments, and political considerations, as well as what research is being done from a diagnostic, preventative, and treatment perspective here and elsewhere. Dr. Colevas is known in the United States and abroad for three areas of expertise. One, multimodality treatment of head and neck cancer. Two, first-in-human and early clinical trials development with a focus on therapeutics for patients with head and neck cancer. Three, new therapeutics in patients with nasopharyngeal carcinoma. Dr. Colevas has over 25 years of experience with the conduct of clinical trials, the oversight of clinical trials, and regulatory aspects of governing clinical trials. In addition, he is a long-standing member of the NCCN Head and Neck Panel, a national body which largely determines standards of care in a multidisciplinary way for head and neck cancer. He has been an active member in the national clinical trial networks of ECOG and ACRN and NRG. He's been a member of the California Cancer Consortium Early Clinical Trials Network. He remains active in research, clinical care, and teaching as a professor of medicine at the Stanford Cancer Institute. Please join me in welcoming Dr. Colevas.
Thanks, everyone. I wish I could see you all live, so I will do the best that I can do without being able to see you live. I'm going to talk about nasopharynx cancer. I'm going to talk about a lot of different aspects about it. Some of this is going to get technical and graphy, and I would ask that you not be put off by the graphs and charts. I promise to explain them in language that we all will understand, not so technical. So first, I'd like to talk about frame of reference. And for frame of reference, I'm going to use a football analogy because when I was growing up, everyone seemed to explain everything in terms of football metaphors. So for some of us, this is what football means. It means America, it means helmets, it means brain trauma, it means even before the game is started, as you can notice, there's some blood on knees. But for the rest of the world, football means something else. Football means what we obscure Americans call soccer. I have to tell you, I'm very partial to football as defined globally because I was fortunate enough to have a daughter who played soccer, and I continue to follow Stanford women's soccer. Go Cardinal, go women's soccer. But I think my point is what football means to you to a large extent depends upon your frame of reference and where you're from. And I think that has an application to what you choose to study as a disease. So here's a map of the United States, and I've marked the San Francisco Bay Area on it. You will want to know that I grew up in Washington, D.C., over on the East Coast, and I remember, everything was kind of East Coast centric. No matter where you grow up, that's your center of the universe, I think. But we were taught to reference the world based on this map. And that's the way we thought of things. There was the United States and there were other places. And I think medicine in some ways is the same way. But what about this map? In many ways, I'm going to talk about something that pertains to people who live in the Pacific Rim. So one of the things that I discovered 15 years ago when I came to the San Francisco Bay Area was I lived in a Pacific Rim city, and in many ways that defined the environment here a lot more than an American city. And it was definitely true for some of the diseases that the patients I took care of had. So let's first by talking a little bit about how people self-identify and how common those people are depending upon your frame of reference. Well, if you ask a global question, how many people out there identify themselves as Asian? It's close to 60% of the world population identifies themselves as being from Asia. So now go back to that map of the US and ask the same question. It's about 7%. California, it's a little bit higher, but in Santa Clara County, our own backyard here, it's over a third. Why does that matter for this talk? Well, nasopharynx cancer, which you'll hear me refer to throughout this talk as NPC, is a disease that is much more common in the Pacific Rim than it is in Europe or the rest of the US. And here's some data. If you look how many people in the world get nasopharynx cancer, it's a rare disease, 1 in 100,000. But look down this table. If you're from Guangzhou, that's not so true. It's about 22-fold higher, about 22 in 100,000. If you're a male in Guangzhou, it's double that. Areas that are considered very high rates of nasopharynx cancer include Singapore and Vietnam. But if you actually cull out a combination of the LA area and the San Francisco Basin area, our rates of nasopharynx cancer here are about as high as they are on the other side of the Pacific Rim. So the point is I think it's been interesting to me to come to this disease, and I now think of myself as more of a Pacific Rim clinical investigator than a US investigator, because the disease I study, I have a lot more in common with colleagues in Hong Kong or Singapore or Guangzhou than I do in Cleveland or New York or Boston. Less so New York, though. So who gets this disease? I'll talk about what the disease is, but first I'll talk about who gets it. People in their 40s and 50s. If you look at this chart, we have what happens if you're in Hong Kong, what happens if you're in Singapore, and what happens if you're in the Los Angeles area. And from this chart, you can see many more people in Hong Kong get this disease, but they all seem to mostly get it from about 40 to 60 years old. Men get it a lot more than women get it. This is the incidence in men. This is the incidence in women. What's happening to the disease over the years? Let's move to the bottom panels. In the 1970s, there was a lot more in Asia than there is now of nasopharynx cancer. The incidence is falling. In LA, however, those incidence rates have been relatively flat in both men and women as compared to that fall in incidence over time. Why might that be? I'll talk a little bit about that in a moment. So nasopharynx cancer. It's okay if you're whispering to yourself, what the heck is the nasopharynx? Most first-year medical students and first-year medical interns can't accurately describe what the nasopharynx is. It's the little box behind your nose, above your throat, below your brain. It's highlighted in red here. Stuff that goes through there. When you breathe through your nose, it goes through your eustachian tubes, the things that you clear when you're popping your ears on an airplane, drain into there. And that's where nasopharyngeal cancers start, as is shown in this diagram, typically on the roof or sidewalls growing downwards. And therefore, it interferes with a lot of the things that we talked about. It can plug your ears. It can plug your nose. You can have bloody noses from it. And that's how often people present. Just for those of you who like images, here is an MRI scan on the top and a PET scan on the bottom, showing a typical patient with nasopharynx cancer, the red star showing you the abnormal structure, which I'm circling with my arrow here. Sorry about that, didn't mean to click forward. That's the tumor. And this shows on PET scan that the tumor lights up because that tumor is very active. And what's a little bit more subtle here is the tumor has spread to lymph nodes on either side of the neck, as indicated by these arrows of a slight glow. This is very typically the sort of scans that we see when people come to us and say, I've had a clogged ear, I have a lump in my neck, I've had a bloody nose, and we see this sort of thing. So what are the causes, or what are the risks for nasopharynx cancer. When I think about cause, I think about something that every single person who has a problem has. And in this case, for this disease, every single person who has this sort of nasopharynx cancer has Epstein-Barr virus, so-called monovirus, in their tumor. So Epstein-Barr virus plays a critical part in development of this disease. However, it's not the only thing, because almost all adults have evidence of having been exposed to EBV, but very few develop nasopharynx cancer. What are the other risk factors? Well, some of them I've alluded to already. If you over here, we talk about family history. That's sort of a surrogate marker of where are you from. For some reason, people from the southern China region have a very high risk. We have not been able to identify exactly what that is, but some of the things that seem to play a role over here, the consumption of salt preserved fish, especially as a youngster, seems to correlate. Tobacco smoke, other things that cause other cancers cause risk, and also your tissue type. So think of HLA when you think about someone getting a heart transplant or lung transplant or kidney transplant. You have to have a tissue match, just like you need to have compatible blood type. They have tissue types. It turns out that some tissue types are at much higher risk than others, and some of those tissue types are concentrated in people from that part of the world. We talked already a little bit about the age where people get this disease, and the fact that men get it 2 to 3 times more often than women for completely unknown reasons. So I'm really not going to talk that much about the details of either of these pictures, but I show them to you for a couple of reasons. We know that the virus, these on the left are the cells lining your nasopharynx. And we know that the virus infects the basal cells at the bottom, sits there for years and years, and then for some reason later turns into cancer and things start heaping up and invading. We know a lot about what the virus looks like. Here is an actual picture of a virus under electron microscope. This is the EBV virus. And we know exactly genetically how that virus is put together. Just like we know completely the sequence of human genes, we also know completely the sequence of EBV. A couple of decades ago, when we were first learning the complete sequence of animals, plants, viruses, we thought that would lead to our understanding them better, and it did, but there haven't been as many leaps forwards. Knowing what something is built of doesn't necessarily tell you how it works. So I put up 3 cartoons of 3 viruses that probably all of you have heard of. SARS-CoV-2 is, of course, the most popular virus these days. That is what causes COVID. It's a relatively small virus. It's these KB are sort of the units of size of the virus. And you can see over here that EBV is a much bigger virus. We've made a lot of progress with SARS in terms of vaccines. This middle one is human papillomavirus. We can vaccinate against that. But we have really not been able to vaccinate Epstein-Barr virus, probably because it's so big and complicated. We hear about variants of SARS-CoV-2. There are so many variants constantly evolving of EBV. It's sort of like a whack-a-mole type problem because it is so complex relative to these more simple viruses. I point out here that many of you have probably heard of a bunch of human diseases that are related to EBV, everything from mononucleosis as a teenager to multiple sclerosis, to certain kinds of lymphoma, to gastric carcinoma. Many things are caused. There's chronic EBV that are thought to lead to chronic fatigue syndrome. We don't know what all of these have in common. What we do know is that the ones above this blue line seem to affect the immune system as a primary cause of the disease. And these diseases below are other areas not directly related to the immune system. So there's a lot here that we would like to wrap our hands around. So, okay, NPC, before we talk about how you might treat it and work being done there, what about identifying it? I've already told you vaccination strategies are not successful yet. There's always hope. Okay, but what about screening? We know how to screen for breast cancer with mammograms, colon cancer with colonoscopy. What could we do for this? Well, there's some blood tests that suggest that you're at higher risk of developing EBV because you've been exposed for EBV for a long time, so-called serologic testing. In some ways, this is very similar to looking at COVID-19 serologies to look to see that you've been exposed. One way is to put a small telescope up everyone's nose and take a look. Very expensive and not exactly untraumatic if you've ever had those procedures done. You could scan everyone with MRIs to look for early tumors, to find them when they're much smaller than the picture that I showed you. You can test for EBV in people's blood, or you can try to combine all of these things to try to figure out who's likely to get it. All of these strategies have been tried, and unfortunately, the conclusion now is the effort to screen everyone to identify a few cases is too enormous. If in the process of looking for 1 or 2 or 3 cases, you have to screen thousands and thousands of people, even in an area of high risk, that's just thought to be impractical. So we're not really screening these days. Are there some people that we might screen that are at super high risk? Well, yes, I told you that there's a family association. So if someone comes and says, you know, my brother, my sister, and my father all had nasopharynx cancer, those are the kind of people that you're going to sit up and screen, even though it's still unlikely that they themselves will get it. Their risk is so much higher than background noise that it's worth doing. So now I'm going to talk about how treatment techniques have evolved over time. There are really no good surgical solutions to nasopharynx cancer. It's in a space where you can't operate. There's too many critical structures and it's too deep. If you remember those original pictures I showed you, it's practically in the center of your head. So in general, radiation therapy and chemotherapy are used, and I'm going to talk a little bit about how those have been used and how they're getting better. So this is a picture of old-fashioned radiation on the left and modern radiation on the right. Old-fashioned radiation, when you got radiated, you would get beamed from either side, and all of these colorized boxes were exposed to very high doses of radiation. So if you had a nasopharynx cancer right in the middle of it, yeah, you could certainly kill it with radiation. But the problem is you'd also kill a ton of normal tissue with very vital structures around that. Big problem. So the reason you couldn't treat nasopharynx cancer adequately with a scheme like that is because the normal tissues around it couldn't tolerate it. In this scheme, however, you'll notice that the curves are much more sculpted, and the brown area, which is supposed to represent the area of highest radiation, really avoids some really important structures like part of your brain or spinal column, part of your mouth, part of your salivary glands, and really radiates where a tumor and its lymph nodes may be. This is probably the greatest leap forward in nasopharynx cancer treatment over the past 30 years, because now you can apply a really high dose of radiation to where the tumor is and spare things that are only millimeters away that are very important not to give high doses of radiation to. So here's a little pitch for thinking long and hard about where one gets their treatment. So this was a little experiment that a colleague of mine did. He took this picture of a person who had a tumor and he outlined the tumor. And he took this photograph and he sent it around the country to a bunch of people who perform radiation. And he said, show me how you would radiate this patient with this tumor. These are the 9 responses he got back. You don't need to know anything about radiation or which is the best technique to recognize that, wow, these maps look really different. They are not at all the same. So the point is, gee, radiation techniques really differ dramatically depending upon who's designing the treatment plan. Does that matter? Well, someone asked that question. In the list of investigators here, you'll see my colleague, Quinn Lee, who's a radiation oncologist here at Stanford. She and a bunch of her colleagues said, let's compare how people do with nasopharynx cancer just based on whether the person designing their radiation plan does a lot of radiation specific to the nasopharynx on clinical trials or not. So they gathered a very large group of patients. It was a bunch of people in clinical trials, and they said, let's lump them into those that were treated by people who do this a lot and those who are treated by people who don't do this a lot. And these are survival curves. The higher the curve, the better your survival. And after 5 years, just based on who did your radiation, there was an 18% difference in survival. Public health message number one of my speech. If you know someone with nasopharynx cancer, make sure they're going to a place that treats nasopharynx cancer day in, day out, all the time, not a place that treats a lot of other cancer and nasopharynx cancer occasionally. Just that one fact, it has a huge impact on how you do. Okay, switching gears, I'm not going to talk really about radiation anymore. I'm a medical oncologist, so I focus on chemotherapy and other systemic treatments. I'm going to walk you through a series of graphs that very rapidly summarize work done by hundreds of investigators with thousands and thousands of patient volunteers over the past 30 years. What you see in front of you is a graph that first demonstrated that giving chemotherapy, top line, with radiation was better than giving radiation alone. This trial is about 40 years old, and the addition of chemotherapy to radiation made a huge difference in survival. Instead of people dying at this rate, a much lower rate and many fewer people dying. That was a huge splash in the 1980s. And upon this basis, all the other trials that I'm going to run through really quickly built upon this. So what we have is, I'm showing you a series of trials that came out subsequently. Next big leap forward, a step up, adding the red line being new chemotherapy treatment. I'm not going to focus on the details of the chemotherapy, but I think you can see that based on these curves, these patients did way better than the original patients. And so on, and so on, and so on. This last pair of curves is the most recent large trial that shows that a new chemotherapy recipe in red was better than the old chemo recipe with radiation in blue. But what I really also want you to take home is that at 60 months for these patients, approximately 90% of them were still alive. So a disease way back when, if you look at this line before, where well over half of these patients were dead at 2 or 3 years, now, based on evolution of chemotherapy and radiation techniques, the vast majority are truly cured. That is a major leap forward that has taken place in very, very small steps. But when you add small steps together, you really make progress. So now I'm going to look forward to what are we doing that you have, I'm sure, heard about on the news, in the press. What about immunotherapy? What is immunotherapy and how does it relate to nasopharynx cancer? So here's a cartoon, and what I mean to represent is here's an immune cell called the T cell, and here's a tumor cell. Immune cells' job are to wander through the body trying to distinguish friend from foe. That friend is any normal tissue in your body that belongs there. That foe could be a virus, it could be a bacteria, it could be a cancer cell. So the way it does it, it has all these hands and probes that are constantly reaching out, trying to shake hands, trying to figure out if the cell that it's bumping up against knows the secret handshake. And what these hands represent is this orange and red hand represents the secret handshake I belong here signal, what I call the don't kill me signal. Now, this, on the other hand, with this blob in here, is a sign that this tumor cell doesn't belong, and this cell gets this handshake and says, wait a minute, there's something wrong here. But it gets the reassuring don't kill me signal, so it says, I'm going to give you a pass. So the first major step forward in immunotherapy was blocking the secret handshake. If you give people certain drugs that block that handshake, suddenly this T cell has a, whoa, this is not my friend handshake, and loss of the secret message, the interfering with the don't kill me signal, this T cell wakes up and says, this cell doesn't belong here, and then attacks it. That is really the basis for most of the immunotherapy drugs that you see advertised on TV, and they call it immune checkpoint inhibition or immunotherapy or antibody immune therapy. Does that matter in nasopharynx cancer? Yes, it does. Now we're no longer talking about patients who come in with tumors in their nose and neck. We're talking about people who have the misfortune of having this spread already throughout their body. The standard of care until very recently was giving chemotherapy to those patients. And while some of those patients had tumor shrinkage, unfortunately, on this gray line, you can see that most of those patients died relatively soon. Unlike that last graph I showed you, this is at 15 to 18 months as compared to 60 months. So until recently, if you had nasopharynx cancer spread to the rest of your body, there wasn't a whole lot of hope for you. But now we add one of those immunotherapy drugs, this one called toripalimab, you don't need to learn the name, that's not important, added to chemotherapy, and suddenly, at the same period, half of those patients that would have died are now alive and their tumors are in remission. That is a huge leap forward. The question now is, how do we best use immunotherapy in nasopharynx cancer? I think it's honest to point out that things don't always work the way we want them to, and I think it's important to show some examples of that. This is not nasopharynx cancer, but it's a graph of patients with cancer of the mouth and throat. The trial was named by the company Javelin. I'm Greek, so I have to show you a Greek urn with a Olympic person throwing a javelin. And here's a modern day javelin person getting ready to launch. But what I'm going to tell you about this curve is really disheartening. In this case, the blue line is the line with the immunotherapy added to standard therapy. So in this trial, not only did immunotherapy not improve survival, it was actually detrimental. So this javelin thrower stumbled. I point that out because immunotherapy of the sort I described is not the only pathway to investigation for treating diseases caused by viruses. What if you could train your own cells to be activated to attack anything that had Epstein-Barr virus in it? How might you do that? Well, you might draw some blood from a patient. You might take their immune cells and stimulate them against Epstein-Barr virus, then grow them up, and then make them really angry to get ready to fight anything that has Epstein-Barr virus and give them back to the patients. So that's a long process. From the time you draw the blood to giving it back to the patient can take many, many, many weeks. And that's a problem because you have to figure out what to do with their cancer in the meantime. This trial's been done. The trial's been finished, and we expect results of that trial this summer. The company behind it's called Tessa. Our participants included a number of West Coast sites, including and excitingly, our colleagues in Singapore and elsewhere in Malaysia and Thailand and China and Korea. So that's one strategy. We call that the auto because we're taking your own cells and giving them back to you after they've been activated. Well, I just told you that's a real problem because it takes weeks and weeks and weeks to do that. What if you could prepare cells in advance from someone else, park them on the shelf, and then just thaw them and give them to someone when they need it? That strategy has also been tried. Basically, blood donors, cells are separated out into their immune cells and their B cells. The technique details are not important here, but basically you stimulate the cells against EBV, you grow them up, you freeze them, and then when you have a patient who has the right blood type and a match who has EBV-related disease like nasopharynx cancer, you give them to the patient. That's also been done, and that trial has finished, waiting for results to come out in the next year or so about whether we see anything worthwhile there. This is what we call a couple of versions of cellular therapy. There's lots of other different types of cellular therapy I'm not going to go into today, but when you hear people talk about cellular therapy, that's typically what one version or two versions of that. So let's go back to this picture. I told you that all of the genes are known. They've been sequenced. People know exactly the structure of all these genes. Can we do something about that to target this virus that's caused cancer very specifically? The answer is we're working on it. So here's one strategy. I think probably a lot of you know there are medicines out there that are used to treat certain viruses like herpes viruses that are called cold sores. There's a similar strategy using drugs that are in the same general class to target how those genes reproduce themselves and to stop that. Those trials are underway. Another strategy is to actually develop a small drug that interferes with the molecule that makes this reproduce. You have to realize a virus, in order to continue to cause cancer in a cell, every time that cell divides, a virus has to be reproduced and goes with it. What if you could block that replication? Well, some very clever people at the Wistar Institute in Philadelphia were able to show that the structure of EBNA1 looks like this pretty party ribbon here that binds to DNA. And then they went on to develop small molecules that would tuck in between these spaces and interfere with that interaction. This is the result of several years of their work where they developed little molecules that could fit in these nooks and crannies that would interfere with binding to the virus's DNA. They call that molecule VK2019. And they looked for someone who was very interested in studying this in nasopharynx cancer. And they came to Stanford, and we have treated the first human beings in the planet with this drug and are finding it safe and are finding that we're achieving good drug levels, but it's too early to say whether it's going to have an impact on their nasopharynx cancer. What I'm going to finish up with, very quickly. These are drugs that are used conventionally in many different diseases. I'm using the name brands here because you may have heard of Erbitux or Keytruda. But what if we use these not as therapies, but to track tumors? If the way these drugs work is by attaching to the tumor, what if we could make them visible in some way to help us find tumors, to help our surgical colleagues look at the extent of tumors? Well, that's been done. And I just want to point out that what you're seeing here on this green glow is these molecules tagged with a glow-in-the-dark material. This is not inside a live human being. This is in tissue taken from a human being. But the idea is, gee, if we can do this in tissue taken from a human being, what if we gave it actually to the human being and tried to see where it is? And I'm going to skip ahead and show you that's what's done up here. This is someone's tongue. You can see here an outline of a tumor. But if you're squinting a little bit and saying, well, if it weren't for that outline, I'm not sure I could see the tumor, I'd agree with you. And this is a major challenge that surgeons face. Where the heck is the tumor? Where does it start and stop? But here, they've been given one of those drugs that's glow in the dark. So they can see now, every place you see this blue blush, they know there are tumor cells there because the drugs only bind to the tumor cells. And this is an example of the glow they see that's been artificially colorized after such tumors are removed, where they can say, yeah, here's the tumor. And yeah, we took enough normal tissue around the tumor so that we didn't leave any of the tumor behind, something which is really hard to do. This work was largely led by my surgical colleague, Eben Rosenthal. I was the person who gave the drugs as part of this study. But this is really could transform surgery. If any of you have ever had the misfortune of having cancer surgery yourself or having loved ones with surgery, the question you all want to know is, after surgery, was the surgeon able to remove it all? This may really help in the future with nasopharynx cancers, tongue cancers, all kinds of different cancers, to help answer that question, did we remove everything we wanted to remove? So the general strategy for something like this is someone comes on a trial, you know they have a tumor, you inject them with these glow-in-the-dark substances, you wait, and then you shine some lights that cause them to glow, and you use that as your roadmap. That sort of work is underway. So I'd like to wrap it up. I hope you have a little bit of a better understanding of what the nasopharynx is, what nasopharynx cancer is, who gets it, struggles with prevention in terms of screening and vaccines, how there really has been a big leap forward in treatment, both because of better radiation techniques and better chemotherapy techniques, and a bunch of these other strategies involving immunotherapy, targeting tumors, figuring out how antibodies work, I think will also continue to transform the field over the next 5 to 10 years in our lifetimes. And with that, I'm going to stop share and turn it back.
Thank you so much, Dr. Colevas, for a very enlightening talk. We have a few pre-submitted questions and one live question. Maybe we'll start with the live question. This attendee is curious about the long-term deleterious effects of older treatments versus newer treatments. So somebody was treated in the past. What are you looking for there? Are there long-term consequences of the newer treatments?
Yeah. So I don't think I used this word during my talk, but a very important term in cancer care is survivorship. So while for many diseases like nasopharyngeal cancer, people are living a lot longer and many are actually cured, at what price, at what consequence? And that's a big deal. So radiation, unfortunately, can have a lot of side effects in terms of scarring, damaging your hearing, making your mouth and throat very dry and very delicate. In a very small number of patients, it can actually induce cancers that develop down the line. So that's one of the reasons that these radiation techniques are really focusing on, can we target just the tumor and not hit normal tissue? Because the less normal tissue you hit, the less likely you're going to develop those side effects. But I don't want to be too Pollyanna-ish. This is still very intense treatment, and it does continue to have side effects. Chemotherapy is, I want to be clear, when one says chemotherapy, it's sort of like saying food. If you have one dish that's spicy and you therefore think all food is spicy, you have to be careful about that generalization. Chemotherapy in systemic care comes in many different varieties. One of the drugs that we use a lot to treat nasopharynx cancer, unfortunately, can cause hearing damage, can damage kidneys, and can cause permanent nerve damage to the fingers and toes, which sometimes doesn't go away. There's other drugs that have other side effects. One of the reasons we're so interested in immunotherapy is that it doesn't seem like immunotherapy is going to have as many long-term side effects. But I also want to put the caveat out there that we really haven't been using these drugs for decades and decades. So there's more uncertainty there. But you're absolutely right. There are lots of long-term side effects that one has to grapple with.
Thank you, Dr. Colevas. On the opposite end of the spectrum, this pre-submitted question, and again, I'd like to remind the audience, if you have questions, please submit them. You can submit them live in the Q&A. First question is, how to protect against this disease? And maybe I'll modify the question a bit. What's, I guess, on the horizon in terms of protection? Are there, behavioral changes? Are there vaccines? Can we prevent EBV infection? Can we change our parents?
Yeah.
What can we do?
I don't know how many times I wish I could trade in my parents for new parents. That was when I was young. Now I'm very glad I didn't change in my parents as I've gotten a little bit older and appreciate all they did for me. So don't change your parents. I think that a point I wanted to make about the curves in, say, Hong Kong versus the curves in LA. In Los Angeles, it seems like the number of people with nasopharynx cancer is relatively flat. In Hong Kong, it's decreasing. That is really curious, and we're not sure why. So there must be something that's changing over time that's causing this to happen less often. What do we think it is? It may be something as simple as a more diversified diet. We honestly just don't know. I told you that virtually all humans are exposed to EBV by the time they're adults. The vast majority of them are exposed to the virus when they're infants. So if we ever come up with a vaccine strategy, it's going to have to be an early vaccine, not like a teen vaccine. But one of the challenges has been, because this is such a big and complex virus, designing vaccines has been hard. But now I'm going to get a little bit technical. Why is it that the Pfizer-BioNTech and Moderna vaccines are so great? Well, they're great for a lot of reasons. But one of the amazing things, and honestly, I believe 50 years from now, when medical historians look back, they're going to write about how quickly we were able to develop a vaccine against a new problem. Poliovirus, measles, mumps, rubella, even once they knew what they needed to make the vaccine against, it took a really long time. The secret is to put the machinery in the vaccine rather than the protein in the vaccine. I actually think that's going to really make the vaccine testing in EBV leap forward, because instead of taking a year or 2 or 3 to try one vaccine to build it and then give to some people, and then find out it doesn't work, and then take another year or 2 to 3 to try another technique, they're going to be able to develop in a few months many, many different techniques and try them. The problem is going to be, how do you figure out whether it has an anti-cancer effect? If a virus that you're exposed to when you're 2 months old causes your cancer when you're 40 years old, does that mean a trial you'll have to vaccinate people in the year 2022 and wait until 2062 to see the results? That is a real struggle. Sorry, probably too long an answer.
No, that was fantastic. Since you brought up COVID-19, next question was, pre-submitted question was, COVID-19, of course, is famous for infecting the nasopharynx, the nasal mucosa. Has there been any visible effect in increasing risk of NPC, or, does it affect patients who have NPC differently?
Not that we know of. There is a spectrum of medical diseases where COVID is much more serious. Mostly it's people with immune deficiencies and certain types of cancers like leukemias. People are particularly vulnerable, but we don't know about that overlap. But one of the things that you have to realize, and this is medical, social, political chaos, is, in the middle of a COVID epidemic, the way you're evaluating and treating people changed dramatically. Your willingness to have people come in for studies decreased. People's willingness. I had patients who didn't want to come in for treatment for their cancer, and I had to convince them to come in because they were worried. So it makes figuring out, is the nasopharynx situation over the past 2 years different biologically because of COVID or socially because people aren't coming in? I think in general, we saw people coming in with later stage disease, but I think that was a social phenomenon because they were staying away because they thought of hospitals as terrible places to get COVID and die, as compared to the biology interacting. That's my speculation.
The next question is on NPC, is a question about men. Why do more men get NPCs? Is there a hormonal link?
I give a little cheat sheet to trainees when they come to my clinic, and I tell them that my 3 favorite words are "I don't know," and I think I like those words because they're the 3 most honest words a human can ever utter. And so I'm going to say, first of all, I don't know, but that never stops me from speculating. I do think there are immune system differences between men and women. In another virus, human papillomavirus, we all think of that in terms of cervix cancer, but you may know that more and more it's also oropharynx cancer. And in the oropharynx cancer population caused by HPV, it's about the same ratio, 2 to 3 times as many men get it as women. Now, HPV people think of as a disease related to intimate contact, and to some extent that is. But even when you control for that, men get it more often than women. And so I do think there is real sex-based biology. We don't know what is underlying that biology, however.
Next questions regarding risk from reflux and GERD. Do reflux, GERD, do those increase risk of NPC?
Not that we know of. Going a little bit on a tangent there, what I didn't talk about is other diseases that are caused by EBV. And some of you may know that stomach cancers are a lot more common worldwide than nasopharynx cancers, but about 10% of them people think are caused by EBV. But we don't think that's particularly related to reflux.
Okay. And then similarly, allergies. Do allergies contribute? Chronic inflammation of the mucosa?
People have looked at that, and the answer seems to be no.
Okay. Next question, herbs. Are there any herbal treatments for NPC? Has that been looked at?
So I'm going to be very careful here. I'm a scientist. I just told you that my 3 favorite words are "I don't know." Something that disturbs me very greatly is using untested treatments because of hearsay. So quinine or hydroxychloroquine for treatment of COVID. It's BS. We know it's BS. But at some point, it was a theory which hadn't been disproved, but that doesn't mean you should necessarily try it. So I get very, very worried when people talk about alternative therapies. And with my own patients, I ask them, oh, someone sent you a little sample of something from North Carolina to put a teaspoon of in your tea every day. What's in it? They're like, oh, my Aunt Bessie sent it to me. I said, that wasn't the question. What's in it? They're like, well, I don't know, but Bessie, I mean, she's Aunt Bessie. It must be good. That's a problem. That is a real problem, because what you should say is, I don't know what's in it. Maybe we should test it. So I apply that to anything anyone calls an alternative medicine. I say, stop, 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 stop. Call it untested. Now, I also want to talk a little bit about the military industrial medical complex. Anyone who pays taxes in the US, part of your dollars goes to crazy searches for weird things that treat cancer. They are dredging up sludge from the bottom of the Indian Ocean. They are going and growing all kinds of weird fungi they've never seen before to see if they're anti-cancer. And some of them have turned out to be great cancer drugs. There's something called apothelone B, which came from the bottom of the Indian Ocean. There's drugs which you may have heard of called Taxol and Taxotere, which come from needles of a very specific pine tree. So I as a scientist, like to keep my mind open to things, but there are so many things that we don't know what they are, and things become popularized. And I worry about that a lot, because when you don't know what's in it, just say, I don't know if it works, and I don't know what's in it.
Perfect nuanced response. Related to the kind of industrial, military, corporate complex, Grail Gallery has made a big splash. I just looked it up. Nasopharyngeal cancer is on their lists of cancers that they screen for. What are your thoughts on Grail and their Gallery test?
So here is a way to look for cancer. So something that's, I'm going to get a little bit technical about DNA. So something that's weird about organisms is we're more leaky than we think. Our cells come off our body. And so if I go break into someone's house, I leave my DNA all over their, jewelry box, etc. And inside of us, our cells leak DNA into our bloodstream. And we're getting really, really good at measuring incredibly dilute and small quantities of DNA. So companies like Grail are saying, you know what? We know certain irregular types of DNA are present in lung cancer, and we're going to test for some of them. Same thing across a number of cancers. For nasopharynx cancer and cervical cancer and oropharynx cancer, they kind of know what to look for. Look for EBV DNA, look for HPV DNA. The problem is, if you have to screen, let's make up a number that's realistic, 10,000 patients to find one person who has it, is it worth it? Even more worrisome is when it's that rare, you may get false positives. So if you screen 10,000 patients, you may get 4 of them that read positive on the test, but only 1 of them is really positive. So 3 people, you tell them, we think you're going to have cancer, and we're going to scope you, and we're going to biopsy you, and we still think you have cancer, and you're wrong. And you destroy these people's lives, and you put them underneath all these procedures. So I'm giving you a worst case scenario about screening tests. And something about screening tests is it's very important to know, is a positive test really positive for what you're looking for? And is a negative test really reassuring? Because that's also a big problem. If you screen 10,000 people and 10 are destined to get nasopharynx cancer and you only identify 1 of them, not a very good test. And a lot of these DNA tests are actually much better for following people who you know have disease, rather than identifying people that you think might have the disease.
Great, perfect. I'm sure that's gonna, in clinic, I've already seen that many patients asking about that test. Last question, and thanks again for joining us. This is a sort of a follow-up to the men have more NPC than women. Is it smoking risk? Is it smoking? Is that more men smoke than women, and that's why there's increased risk? And overall, is that, how much does that increase your NPC risk?
Yeah, so there's a whole area of study, cancer epidemiology, where they try to sort out these questions. And in this case, that has been sorted out. These are are they dependent or independent risk factors? So for example, it is possible that tall people have more head trauma than short people. And that makes sense. They hit their heads on doorways because they don't make doorways. And that sort of is linked. But on the other hand, what you can do if you have enough people with a certain disease is you can say, I'm going to risk adjust to figure out whether tobacco is causing another problem or is actually a secondary risk. So the way you do that is you find a bunch of, distilling it down, let's look at non-smoking men and non-smoking women. Do they still have a higher NPC rate? And the answer is yes. There's very fancy ways of doing that, but that's basically what they're doing, is they're separating the risk. So tobacco is an independent risk. It's not what's explaining the sex difference.
Fantastic. Thanks so much for joining us today. What an enlightening talk. The way you explain it is also so clear and very methodical, so appreciate your time today. Thanks to the audience for joining us for our monthly talks on Asian health topics. Our next community health talk will be on May 31st on health, illness, and social support in the Asian American community with Dr. Grace Yu from San Francisco State University. Please register, and please see us at care.stanford.edu. And again, great thanks to the Vincent V.C. Wu Foundation for underwriting these series of talks. Thanks again, Dr. Colevas.
Thank you very much, Dr. Lin. This is a great program.